Sorry? Henry Thomas. No, I'm afraid that is the wrong answer. So I'll go on to the answer. Tim McElwain and Ray Paulus in 1983, when India won the first Cricket World Cup. That time they reported a first autologous bone marrow transplant. The first ever bone marrow transplant in myeloma was reported by E. Donald Thomas, but it was an allogenic transplant. This was in 1983 when they did it in plasma cell leukemia. And they utilized high-dose IV melphalan. So Dr. Nitin, have they answered the other teams?
Team A, Team C, Team D all get it correct with 10. Team E gets it wrong.
Okay. So the index team did not answer, but A, C and D answered it correctly, so they get plus 10 each. Can we move on to the next question? Can we move on to the next question? So this is the direct question to Team C. Control your adrenaline, you have to answer after 20 seconds. So they pioneered first tandem transplant in myeloma. It was first attempt at curing myeloma. Who are they? Name any one. Time starts now. Control your adrenaline. Time is up. Yes, now you can answer.
First one is Barlogi, second one is Seema Singhal.
Excellent. What is Barlogi's first name? That's fine, I'll give it to you. So Bart Barlogi and Seema Singhal from University of Arkansas, they conceptualized the total therapy concept, which is basically utilizing all active anti-myeloma drugs into the anti-myeloma treatment in order to curing it. There were multiple protocols, total therapy 1, 2, 3A, 3B, 4, and nowadays there is even 5. And with the total therapy 3A, the 10-year survival is to the tunes of 57 to 60%, which is very good at 10 years. So did the other teams answer correctly?
Yeah, so we need the quizmaster's opinion on this. Team A and Team E have got only one answer, right?
That's correct. So what is the answer which they have written?
They have written Barlogi.
That's okay, I'll give it to them. I'm very generous at giving marks.
So Team A, Team E and Team D all get it correct.
So Team A, E and D get plus 10 and Team C gets plus 20 for their correct answer. Okay? Can we move on to the next question? Scorer ready, timer ready. So this is a direct question to Team D. He was trained as a surgeon, known for his paper in 1971 in NEGM. NCA grant reviewers turned down his proposal, stating it is common knowledge that hypervascularity associated with tumors is due to dilation of host vessels and not new vessels, and this dilation is because of the side effects of dying tumor cells. Therefore, tumor growth cannot be dependent upon blood vessel growth any more than infection is dependent upon pus. In 1998, a reporter quoted Nobelist Watson saying that he is going to cure cancer in 2 years. Who is he? Time starts now. Team D.
Is he Folkman?
Can you tell the complete name?
I don't know, Folkman. It's called a
That's okay, I give it to them. So Team D has answered it correctly, they get plus 20. Other teams?
So Team C has got it right, and Team A and Team B have got it wrong.
A and C got it right.
No, only Team C, A and B are wrong.
C, oh, okay. So C gets plus 10 and D gets plus 20. It is not moving. Slides are not moving for some reason. They're moving now. So the name is Judah Folkman. He showed that small tumor spheroids suspended in the avascular antechamber of the rabbit eye did not increase in size. But when they were placed in another position in the iris, which is a highly vascular area, they were able to rapidly induce and attract new blood vessel capillaries. And his mentee, Robert D'Amato, he first described anti-angiogenic property as thalidomide in his in vitro assays. And when he was first told to look for the anti-angiogenic drugs, he saw that those drugs which have a side effects of inhibiting blood vessel growth, they can be used therapeutically. And one of those drugs was thalidomide because it inhibited limb blood vessel growth, because of which it caused limb agenesis, and that is why it is very potent at inducing or inhibiting angiogenesis. That's the theory behind it. So question 5, this is a direct question to team E for elephant. Okay, timer is ready. Okay. In 1844, Mr. X, a 45-year-old tradesman from London, developed sudden onset chest pain while on holiday in Scotland. Developed the pain as if something was snapped or given away within the chest. Mr. X had also noted that body linen was stiffened by his urine. His treating physician, Dr. William McIntyre, observed albuminous protein precipitate formed when Mr. X's urine was warmed, but it redissolved when heated to 75 degrees and formed again upon cooling. Mr. X's urine sample was referred to a chemical pathologist at St. George Hospital, London, in the picture below. The question is, who was Mr. X? Your time starts now. Okay, have other teams given their chits? I guess they already have. Team E, your answer.
It's a guess. Ben's John.
No, that is wrong. So the correct answer is Thomas Alexander McBean. The picture shown was of Henry Benz Jones. It was only meant to confuse you. So this was the answer. Did other teams write that answer?
Team A and Team D get it correct.
A and D for Delhi. Okay, so team A and D for Delhi get plus 10, others 0. Now while our scorer calculates, it's time for the audience to pump up some adrenaline. Audience question, who are they? Please stand up. A hint is in the right panel inset above, because that was a time when first Cricket World Cup was played and it was won. In that same year, something was done by these two people. If somebody wants to answer, they can stand up and answer. 1 minute. First, no, stand up, that's it. Please identify yourself.
Dr. Chinno from Manipal Hospital.
Right, please tell your answer. Dury and Salmon. What is the first name?
Barney Dury and Sydney Salmon.
Brian Dury and Sydney Salmon. Yes, correct. Thank you. So Brian G.M. Dury and Sydney Salmon, because they described a Salmon-Dury staging in 1975, and this is the extensive staging which has been described by them. So before going to round 2, scores.
All right, if any teams have any clarification with the scores, please do it after each round or hold your breath forever. Team B is yet to open their accounts. They're taking it like a test match. Team E is on 20 points. Team A is on 30 points. And tied in first place, neck to neck, is Team C and Team D with 50 points.
Thank you. Don't worry, we have a lot of rounds to play and you can always catch up for it. So going on to round 2, there is a difference between walking versus running. If you say that you walk, you might lose weight, but if you run, you will definitely lose weight. So this is the same scenario when it comes to marks in the quiz. So in this case, we'll start from team B first, B for Bombay. Each question has 2 parts. In this case, for example, in the index team, if it is team B, they have 2 parts. Correct answer for both questions plus 30. Only for one question, means either first part or second part plus 20. No negative marks. Other teams to submit answers at the end of each part of the question, which means first part or second part. If their answers are also, both answers are correct, it will be plus 20. Only one answer is correct, plus 10, no negative marks. The time will be 20 seconds, timer, for each part of the question. Index team to answer only after other teams have submitted their answer sheets to the volunteer. Clear? This is a sample question. Team B can take this. Currently the most talked about person in media. Who is he?
See. Example question.
So index team waits for other teams to submit their answers. They did not answer. You assume that. And finally we have a smile on team B's face. That is Lionel Messi. So if this is the first part of the question, after this answer, index team answers are acknowledged as right or wrong. Marks are not given at this stage. Other teams' answers are collected. They are not disclosed. So the scorer to please keep the answer papers of first part and second part with you. Second part of the question. Lost the finals but won huge respect. Who is he? I am assuming that other teams are not answering. And at 20 seconds, index team answers. So index team, what is the answer? Full name. Poor man, he scored 3 goals, but people know only the latter part of his name. That's fine, I'm very generous, I'll still give it to you. Kylian Mbappe. So after the second part, if both parts are right for the index team, then they get plus 30. If only one part is right, plus 20. Both wrong, 0. The other teams, both parts right, plus 20. Only one right, plus 10. Both wrong, 0. Clear? Anybody wants water? No. So here we go. You want water? Ayush? I'm not sure I'm that grilling an examiner that you want water. I want water, yes. But I cannot say that. Okay, so here we go. Question 1 to team B, B for Bombay. This is part 1. A 29-year-old male presented to emergency with hypocalcemic tetany, 5-month history of diarrhea with weight loss. CBC values are there in front of you. Ferritin is there in front of you. A and B shows biopsy. C and D shows IHC. There is one clinical picture, and on the extreme right we have serum protein electrophoresis immunofixation. What is your diagnosis? Index team to wait. Time starts now. Please collect the answer papers. So please keep the answer papers with you. Don't disclose whether they have said it as right or wrong. Now you can answer.
It's alpha heavy chain disease.
Alpha heavy chain disease. And why do you say that?
Because this patient is having an intestinal involvement causing chronic diarrhea, malabsorption, and as well as he is having cachectic symptom, and also he is having iron deficiency anemia, and he is having pan-digital clubbing. And number 2, the histopathological examination is showing lot of plasma cells involvement, and immunohistochemistry is having IgA positivity and
IgM is negative.
IgM is negative. And serum protein electrophoresis is having a spike in the beta globulin region, as well as in immunofixation. I can see there is a dense thick band which is seen in the IgA region that corresponds to the beta region. So it's an alpha heavy chain disease.
Excellent. Looks like a thesis is an alpha heavy chain disease. So the answer is alpha heavy chain disease. Mediterranean lymphoma, as is correctly described, GI malabsorption symptoms, presence with iron deficiency anemia, hypocalcemia, clubbing. Biopsy, you show the lymphoplasmacytoid cells which are infiltrating the lamina propria. IHC, IgA is positive. And similarly on immunofixation, there is only IgA restriction. So this is alpha heavy chain disease. So question 1, part 2. Timer is ready, scorer is ready. Okay. This is also to team B, B for Bombay. Identify this concept of multiple myeloma. Time starts now. Time up. So please collect the answer sheets. You want to give or you don't want to give? Then please give. Yes, team B.
This is called light chain myeloma. This is called light chain escape phenomenon.
Light chain escape. Why do you say that?
Because while starting the
It's okay. So you can see that. Is there a laser here? No. So you can see that the IgA component, which is in the blue, is coming down, but the red component with serum kappa free light chain is going up over a period of time. This is called as light chain escape. So this is light chain escape, rising monoclonal free light chain production without an intact monoclonal immunoglobulin, first observed in the early 1960s by Professor Jack Hobbs, and estimated incidence is 2.5% myelomas at relapse. So scorer amongst the other teams who all answered both correctly.
No one. Team C and Team D have got only one part of the question.
C
right?
and
D.
C and D. They got one part, which means they get plus 10. Team B for Bombay, they got both parts, which means get plus 30. Excellent. Coming on to question 2. This is for Team C. Scorer ready, timer ready. Okay. 60-year-old man present with confusion, progressive cognitive decline, slurred speech and ataxia. A brain MRI shown in panel A. Immunofixation in the second. CSF morphology in third. And CSF flow cytometry findings are present in front of you. 45 moderate, 20 moderate, 38 moderate, 10 negative, 5 negative, surface kappa moderate, surface lambda negative. Likely diagnosis. Time starts now. Please collect the answer sheets. Yes, team C to please answer.
Canomat syndrome, chronic progressive ataxia.
Incorrect. The correct answer is Bing-Neil syndrome. It has two types. Type A involves the parenchyma, type B involves the leptomeninges. When you go back and see this, you can see that in panel A, the arrow mark shows leptomeningeal enhancement. There is IgM kappa restriction with cells in the CSF which are lymphoplasmacytoid morphology, and they have positive markers of both B lymphoid lineage as well as the plasma cell lineage. There is 20 moderate and 38 being moderate. So this is the cells which is infiltrating in the brain or in the CSF. So here the correct answer is Bing-Neil syndrome. Question 2, part 2. This is the direct question for team C. Timer ready, scorer ready? Okay. Mutated L265P is the most common mutation in Waldenstrom macroglobulinemia. What is the most common cytogenetic abnormality? Time starts now. Please collect the answer sheets. Yes.
12Q.
Sorry?
12Q
12Q deletion amplification क्या?
deletion.
Wrong. The correct answer is deletion 6Q, which is the most common cytogenetic abnormality in Waldenstrom with a frequency of up to 54%. And it is much higher than other B-cell disorders. There are two tumor suppressor genes, BLIMP1 and TNF-AIP3, which are on that region, which get deleted in this chromosome deletion. So Dr. Nitin, other teams have they answered it correctly?
Yeah, Team D has got both parts of their question correct.
D for Delhi. Yes, so D for Delhi gets plus 20. Others, not even one.
Sorry, Team E has got Bing-Neil correct. Team B has got Bing-Neil correct. Team B and Team E
B and E, Bombay and Elephant.
have got one question correct.
So B and E get plus 10 and D get plus 20. C, no marks. We move on to the next question. Scorer ready, timer ready? So this is a direct question. I'm sorry it is written Team C here. This is a direct question for Team D. My apologies. Part 1. 49-year-old male with fever since 6 weeks. There is pedal edema, ECOG PSS2. CBC values are in front of you. Renal function test normal. SGOT, SGPT, alkaline phosphatase, LDH normal. Total protein 4 grams, albumin 2.5, globulin 1.5, and the CT scan pictures are in there in front of you. This is a lymph node biopsy picture in the upper panels along with the respective IHC markers. These are the bone marrow biopsy images. What is the diagnosis? Time starts now. I think the bell is, it may just die out in some time. Yes, Team D.
Is it poems?
Incorrect. So the correct answer is Tafro syndrome, thrombocytopenia, anasarca, fever, reticulin fibrosis, organomegaly. If you go back and see here, in the bone marrow biopsy, you can see reticulin fibrosis in the extreme right and megakaryocyte clustering with hypoplasia in the middle inset. And you get a phenomenon similar to idiopathic multicentric Castleman disease in the lymph node biopsy. That constellation is a variant of Castleman disease that is called as Tafro syndrome. Sorry? So we move on to question 3, part 2. This is also the direct question to Team D. The person in the red shirt, can you please stop playing with the bell? You have the bell with you or no? You will shout out, the time is up. Okay. So your vocal cords will go for a toss. Question 3, part 2. This person used a drug to treat himself. What drug did he use? Time starts now. Yes, time is up. Please collect answer sheets fast. Team D.
Is it corticosteroids?
Ayyo, if it was steroids, I wouldn't ask this question. So he's David Fajgenbaum. He's a co-founder of Castleman Disease Collaborative Network. Unfortunately, he is himself suffering with multicentric Castleman disease. In 2012, when he nearly died and his priest had come to say his last rites, that time he was treated with anti-IL-6 therapy. Consequent to that, he had multiple relapses. And later, he found out that the central part of Castleman disease pathogenesis is mTOR, which ultimately leads to everything. He has written a book called as Chasing My Cure, one of the most inspirational books you can ever read in life. And the drug which he used was his next door drug, sirolimus. You can see his photos before he got ill and after he got ill. The worst before and after photos in history. So the correct answer here is sirolimus. So, scorer, other teams, both questions correct?
No one.
No one. One answer correct?
So someone has written only David Fajgenbaum.
The question was, what drug did he use? So that is incorrect. So no one. Team D, none. Okay. Everybody is 0. Okay. So we are happy, at least our headache is less. Question 4. This is a direct question to Team E, E for elephant. Scorer ready, timer ready. Part 1, 70-year-old male, evaluated for high creatinine, 2.3 grams, baseline is 0.8, 12 months back, otherwise no symptoms. Serum protein electrophoresis showed an M band of 0.2, immunofixation shows IgG kappa, SFLC ratios in there in front of you, other labs are there, CBC, creatinine, potassium, phosphate, protein albumin, bicarb, uric acid, sugar, urine routine microscopy, 24-hour urine protein, C3 level. These are the images, the microscopy report on the top panel, IHC report for the kappa on the right, immunofixation for immunofluorescence for kappa and lambda below left, electron microscopy below right. What is the diagnosis? Time starts now.
Ayush.
So can you go to the previous slide?
Please collect team E's answer also. So team E, yes.
Sir, can we see the image? Okay.
Answer it now or never.
Amyloid with cast nephropathy.
Incorrect. So the correct answer is light chain proximal tubulopathy. So if you go back to the question and see here, he has renal dysfunction, yes, but he has symptoms of Fanconi syndrome, wherein he is losing some proteins and glucose in the urine, that too at normal blood sugars. His uric acid is on the lower side, his bicarbonate is on the lower side. There is some proteinuria which is typically a tubular proteinuria, not glomerular proteinuria, and he has a small monoclonal band, and this is called as the spectrum of MGRS. If you look at the light chain microscopy, you can see those inclusions, kappa light chain restriction, and on the electron microscopy you can see rhomboid crystals which are there in the tubules, which are typically the kappa light chain crystals. So correct answer here is light chain proximal tubulopathy. You get tubular vacillation light microscopy, inclusions which appear rhomboid shaped and which are restricted on the immunofluorescence and IHC. So coming to question 4, part 2. Scorer ready, timer ready? Okay, this is for team E. Risk for MGUS progression to myeloma is 1% per year. In MGRS, what is the risk for progression to myeloma within the first year? Time starts now. Please correct answer papers. No, they don't. Team E.
Yeah.
Team E, please say your answer.
5%.
5%. No, that is incorrect. Correct answer here is 10%. There was a big study of 2,935 MGUS patients, and they saw that when compared to MGUS, MGRS patients progress at 10%, especially in the first year of diagnosis. Nitin, any other teams who have answered both correct? None. Any one correct?
So you wouldn't give marks for light chain deposition disease and cast nephropathy, no, for the first
No,
part?
that is incorrect.
No.
So, none. Okay, I'm sorry. Timer ready, scorer ready. This is for team A. Direct question. 52-year-old male who has presented to you with abdominal pain and shortness of breath. The CBC values are there in front of you. M protein is 1 gram per deciliter, which is IgG kappa by immunofixation. In view of breathlessness, somebody does an X-ray and a CT chest, which is normal. A bone marrow biopsy shows 8% clonal plasma cells with erythroid hyperplasia. These are the pictures wherein a procedure is performed. That procedure is termed as X. You have an investigation, a baseline, immediately after X, and in the 5th or 6th heartbeat after X. Question is, what test is being done here? Time starts now. please collect.
Not from them, not from them.
Team A. No answer. This goes on to the audience.
Bubble echo. It's called a bubble echo or a saline agitation echo for demonstrating intrapulmonary shunting as a part of TEMPI. I think if that line
Excellent.
diagnosis is
So this is a 2D echo with agitated saline contrast. If you get that bubbles on the left side of the heart, in the left atrium and left ventricle, which you can see in the panel 3 on the top right panel, if you get it in the first 3 heartbeats, it is typically suggestive of an intracardiac shunt. After about the 4th heartbeat up to the 8th heartbeat, intrapulmonary shunt. Typically in intrapulmonary shunts you will not see bubbles because the pulmonary capillaries will absorb all the air. But if there is intrapulmonary shunt, these bubbles can pass on to the left atrium. So this was TEMPI syndrome, but the question here was what procedure was being done. So we'll move on to the next question. Nitin? Question 5 part 2. This is for team A, direct question. In this disease entity, amongst patients who relapse, which is the most sensitive marker of disease relapse? Time starts now. Please collect answer papers.
Is it
Don't write a very long
Yeah,
answer.
yeah.
Yes, team A.
the free light chains?
Wrong. Correct answer is erythropoietin level. So in TEMPI, the second letter E stands for erythrocytosis, and in those patients who have relapsed after initial therapy, it has been seen that the most sensitive marker of relapse is the elevated EPO level. It is followed thereafter by the rise in monoclonal gammopathy and the appearance of skin telangiectasias, described in 2020 by David Sykes. So Nitin,
So
2 answers correct.
no one.
No one. 1 answer correct.
One team had written for the first question, right heart dicatheterization showing bubbling suggestive of intrapulmonary.
But it was not a right heart catheterization. Incorrect.
All right. Team C has got one part of the question correct with
Which one?
erythropoietin levels.
Okay.
being
So
written.
team C gets plus 10 here. Others nil.
We gave the answer as erythrocytosis.
That is incorrect. What is the marker? Okay. So end of round 2. While our scorer calculates the scores, it's time for the audience to get rejuvenated. Audience question. Yes, prizes, but they are not visible. Audience question. Whose symbol is this? Fill in the blue blocks. Can you please stand up and answer?
Is it IKMG?
Excellent. Can you expand IKMG?
Yeah, this is the international group for monoclonal gammopathy with kidney diseases.
Yes,
And
so
they
IK
define
will be
the-
kidney. So
Yeah.
international kidney,
Monoclonal
gammopathy
gammopathy
group.
group, yeah.
Excellent, Dr. Arun. Keep a big hand of applause for him.
Right. So team A did not score anything in this round, so they
Okay.
stay on 30 points.
Okay.
Team B have managed to hit a lot of boundaries, scored 40 points, and their score is 40.
Excellent.
Team C staying steady and have scored 20 in this round and are on a total of 70 points.
Excellent.
Team D also with some boundaries, scoring 30 with a total of 80 points.
Good.
And Team E with one boundary with 10 points, staying on 30.
Okay. The correct answer is International Kidney and Monoclonal Gammopathy Research Group. Founded in 2010 and in 2012, they introduced the term MGRS to describe those hematological conditions that produce a monoclonal immunoglobulin associated with kidney injury. I hand over the dais to Dr. Karthik Bomanan for the next 2 rounds.
So now let's start. So round 3, these are the rules. So index team answer with this round is called clueless. Okay, index team answer without clue, 40 points, but there's no negative marking. Okay, but answer with clue, you get 20 points. So once you take the clue, you have to answer. If you don't answer, you get minus 10. Even if you give an incorrect answer, it is minus 10. Clear? And time to answer is 20 seconds per part. And question will pass to other teams only after the clue. Okay? And correct reply, you will get 10 points, and incorrect answer, you will get minus 10 points. So from this round, you will be penalized for your negative answers for the teams who are answering apart from the index team. And submit your answers only if you are sure. So the clue part, the index team to answer only after the second teams have submitted their answers. So in case if the primary team doesn't want to take the clue and they don't know the answer in the first go itself, then they are out of the competition for that question, and the clue will be displayed and other teams are bound to answer. So answer cautiously the non-index teams. Right, clear? Any doubts? Right, we'll go ahead. So let's begin. So question 1 goes to team C. Right. So this is the question. 60-year-old female, fatigue and low backache and right groin pain. These are the hemogram values. Patient having splenomegaly and also having a MGUS range of M protein, and there are no osteolytic lesions, and bone marrow gave clue for diagnosis. And this is the imaging. What is the primary diagnosis? Right. So you want to answer? I want to take a clue. So if you're going to take a clue, so sure, so you have to answer. If you don't answer also, you will be penalized. Right.
So teams can write their answers now and be giving.
Right. Meantime, we'll give the clue. Right. This is the clue. This is the bone marrow finding. So time's up. So team C.
Wait. They have to give them.
No, negatives.
Negatives are there.
Negatives are there. Incorrect is right. Right. Yes.
Waldenstrom's macroglobulinemia.
No, we'll take only the first
sorry.
thing. No, we have only the first thing. So what is the second thing which you want to answer? But you will not take it. So the answer is, anyone from the audience? Yes. Answer is Gaucher's disease. So MGUS in association with Gaucher's disease was reported early as 1968. The risk of myeloma is affected individuals with 25 to 50 fold higher in patients with Gaucher's disease, especially type 1 disease. So it's Gaucher's with MGUS.
So team C gets minus 10.
Minus 10. Minus 10. So none of the other teams attempted, right? So anyone regret not answering? Any of the teams? You regret. Fine. So question 2 to team D. Fine, let's go ahead. So 60-year-old male, multiple osteolytic lesions, and M component is 5 gram per deciliter, immunofixation IgG kappa. This is the bone marrow aspiration findings. We are getting cells, smaller cells and larger cells, and these larger cells have something like this. Okay, and this is the lower view of the bone marrow biopsy, and next panel below is the hyper view, and this is the IHC for kappa, and this is the electron microscopy finding. Time starts now. Wait.
No, they're not answering, right? It is without
No, you
clue.
can ask
I
them.
can
No?
answer, right?
Okay, fine.
Is it scler myxedema?
No. So now we will go with the. Now we have already answered. You cannot take the clue also, right? They can still take, right? Okay, this is a clue. Large cells are CD68 positive. The large cells are CD68 positive. So if you submit the answers, if it is wrong, you will be given negative marks. Be reminded of that. So anybody, no one wants to answer? You want to attempt?
No, pass.
Pass. Okay. So anyone from the audience?
Crystal storing histiocytosis.
No, it's crystal storing
Crystal
histiocytosis. Good. So now team D. We wrong. Right. So minus 10. No, after the clue. No. You did you take that clue, right? You wanted the clue, right? You wanted the clue, right? Huh.
No. So the question we are asking is, did you take the clue or not? You took the
You
clue,
took
right?
the
So
clue.
once you take the clue, irrespective of whether you answer incorrectly or you do not answer, it's a negative. So you need to say, I do not want the clue and I'm out of it.
Right? So clear? So answer is
Minus 10.
minus 10. So it is crystal storing histiocytosis. So let's go with question 3. Team E. So 60-year-old male, multiple lytic lesions, normal renal parameters, normal serum calcium, hemoglobin is 130 gram per liter, and urine BJP was negative. This is the bone marrow aspiration showing 70% plasma cells, and this is the immunofixation electrophoresis and serum free light chain assay. This is the report. Fine. So name a commonly available investigation to establish the clonal nature of these plasma cells. Time starts now. Right. You want to go?
Kappa lambda restriction.
IHC.
Okay, we'll give it to you. Yes, good. So the clue was this: search over or inside the cell. So can you tell me any other modality where you can identify the clonality of the plasma cells? You will not get any extra marks for this.
Flow cytometry.
Yes, perfect. 40. Good. So you can identify the phenotypic aberrancies, surface markers. Okay. By IHC, whatever you want to demonstrate something inside the cell. So by doing an immunohistochemistry by the kappa and lambda, you know whether it's a truly non-secretory myeloma or a non-producing myeloma. That's good. So question 4 to team A. Right. So from the collage of pictures, give the diagnosis. Your time starts now. Right. You want to answer?
We are out of it.
You don't
No,
want. You
no.
don't want the clue also.
Don't want.
So now, now I will be revealing the clue now. So now the other teams are out to answer. Yeah. This unique entity responds to B cell directed therapies rather than plasma cell directed therapies. So if you can attempt, if you are correct, you will get marks. Otherwise, you will get minus 10. So you will reveal the answer. Done? All teams done?
Yes.
So answer is Canomat syndrome. Who had got it correct?
So team C gets it correct.
Right. So
Team D, team E, and team B all get it wrong.
okay, minus 10. You give minus 10 for each, and team C plus 20, right? Plus 20. So team C plus 20. Whatever.
I think it was plus 10. It was
Okay.
for the pass. It was
Plus 10. Plus 10. Sorry. So team C gets plus 10. Team D, E, and B, right? B for Bombay. They get minus 10. Right. So now all your marks are being. Yeah. Okay. Right. So 10-year-old. So now question is to team B. So 10-year-old girl with tetralogy of Fallot was investigated for recurrent episodes of pneumonia. Her hemoglobin platelet counts were normal. She had leukopenia with absolute neutrophil count of 300. This is the collage of images based on both clinical and microscopy and immunofix and electrophoresis. Probable diagnosis. And the time starts now.
They can answer no.
This is WIM syndrome.
Yes.
What's hypogammaglobulinemia, myelocathexis,
Good.
everything is there.
So you get plus 40. Yes. It doesn't pass. So they got it. So the clue was this. What is this clue?
This is GCSF just to mobilize Pelixafir to mobilize the neutrophils into peripheral blood.
Yes. Perfect. So team B gets 40 points. Rest of the team gets no points. Good. So audience question. What color ribbon is Waldenstrom macroglobulinemia? This is burgundy color for multiple myeloma. What is it for? Yes. So we got someone with the answer. So you didn't attempt for right. So it's pearl color.
Right. So, Team A, batting like Rahul Dravid, staying solid and defensive on only 30 points. Team B, smashing some boundaries and have scored 30 in this round, plus 40 and minus 10, and have gone on to 70. Team C are holding fort, plus 10, minus 10, and are staying on 70. Team D have lost some wickets and have come down from 80 points to 60 points. And Team E got a free hit and then lost a wicket to score only 30 points and are now on 60. So Team A on 30, Team B on 70, Team C on 70, Team D on 60, and Team E on 60. It's about as close as you can get.
Right. We are going ahead for a tiebreaker, most likely. Okay, fine. Now let's go with the other round. So be very cautious. From these rounds on, we will get negative markings, right? So round 4, let's gamble. Okay. So don't lose hope. Now it's time for gambling. You can double up your scores. So for a direct question, plus 20 points, no negative markings. Okay. Time is 20 seconds. So once you got this answer correct, then you will be given the option whether you can gamble. So you can opt for the second question. So if you get it correct, you will get getting 40 points. But if you are incorrect or no answer after opting for your gamble, you will be given minus 20 points. Okay. So be very cautious. So first question, if you answer plus 20, there's no negative marking, but you will be given an option of gamble or not. If you accept for a gamble, then you are bound to answer. If it is correct, fine, 40 points. Incorrect, minus 20. If you don't answer, also minus 20. There is no pass. So it's time for each team to boost up their scores with no competition, right? Now question to team D, team for D for Delhi. Question 1, in the list below, which is the surface antigen present on both malignant and polyclonal plasma cells? CD117, CD28, CD229, and CD33. Time starts now.
CD 229.
Yes, 20 points. So it's a gating marker, right?
Ask them if they want.
Okay, do you want to go for a gamble or not? You can get 40 points. Go for gamble? Sure? Good. Fine. Good. So if you are bound to answer now, if you don't give an answer, incorrect answer, minus 20. Let's see. This is answer. So name the clusters of differentiation nomenclature of the molecule to which elotuzumab binds. Should be very specific in the answer. Time starts now. Yes, bingo. So you got 40 points. Good.
So plus 40, right?
Plus 40. Good. So see, they have really developed the points. So we didn't want the slam up 7. If you have told that, it would have been minus 20. So any team had the answer for this? Good. But there is no pass. So you are not in the competition. So now question 2 to team E. So what is this assay where FX cycle violet is a nucleic acid binding dye? Identify this assay and your time starts now. Answer please. Whichever. What is this assay being done? Yeah. Okay, the test. Yeah.
Time's up.
Answer.
Multiparametric flow cytometry.
No. We want to specific with the
Yeah.
answer. Yeah. No, test. What is being analyzed here? There's no negative marking. Okay. We will go.
So do they want the second part?
You want the second part? No. Okay. But no other teams are in the competition. Now let's reveal the second part. Okay. So this is flow DNA analysis, cell cycle analysis, or ploidy analysis. Okay. So second part was which parameter identified by this assay is included as a variable to define high risk myeloma as per MSMART 3.0. Any team wants to answer? Will not be penalized. Which parameter found
anyone
through
in
this
the
assay?
audience also?
For the audience also can participate. Which one? Yes, S-phase fraction. So this assay can give both the ploidy status and the S-phase fraction. Right? So team E doesn't get any points, right? Right. Okay, now next question goes to team A. Right. 60-year-old government officer was diagnosed with multiple myeloma, IgA lambda paraproteinemia. Currently on treatment for his relapsed disease. The immunofixation letter for this during his follow-up is like this. Okay, this is the immunofixation letter for us. What additional information does the pathologist require to exclude a biclonal disease in this scenario? Time starts.
Flow cytometry.
No. Okay, why you told flow cytometry? Just out of curiosity.
He suggested.
Right, fine. Okay, now you're not getting any marks.
No, ask them whether they want.
You want to gamble?
No.
No? Sure? Okay. So this is any monoclonal antibody interference or direct interference, right? Okay. So you don't want to gamble. So the gamble question was this. Name an assay which can identify the paraproteinemia in myeloma patients on daratumumab. Yes, that is one of the answer. What? Can you, no, I can't hear you properly. Yes. So both are correct. So you didn't take the gamble. Right. So no marks for anything. So everyone is playing safe. Take motivation from team D. They scored 40. You still have a chance of doubling up your scores here. Okay. Question 4 to team B. So which assay identifies this epitope? Time starts now. Fine?
Shall I answer?
Sure. You want to answer?
You
You want to
can
answer? Yeah, go ahead.
Serum free light chain assay can identify this epitope.
No.
Free light.
No. So this, what is the epitope identify here? It is a binding site between the heavy and light chain. It's a heavy light assay. So you're not getting any points. So still want to go for gamble? Right?
So they're going, not going.
No, they're not going. They're not going. So heavy light assay. Right. So the gambling question was 60-year-old male with multiple myelitic lesions. Bone marrow had 70% clonal plasma cells. M protein is 35 gram per liter and is IgG lambda. And serum creatinine is 3 milligram per deciliter and creatinine clearance is 22. You have received these results for serum SFLC. Okay. So what will be the normal SFLC ratio you will be using to interpret this result, the SFLC result? So what will be the ratio you might be using in this particular scenario? So you will not be getting any positive or negative marks. Just can anyone wants to attempt? Yes, that is Hutchinson's ratio. So you could have taken the option, right? So no one knows what is inside the box. Okay? Right, no one gets anything. I am feeling very happy for myself. Okay, now question 5 to team C. Okay. What is this technique? The time starts now. You want to go ahead?
Yes. Immunosubtraction. Immunosubtraction.
Immunosuppression. Can you be more
Subtraction.
specific because
Immunoselection. Selection.
you want a specific
Subtraction.
word to be added here because very specific because that can be done by multiple things, right?
Immuno.
Because we are putting the beads and every time we are checking the supernatant for what is left, and it can be used in place of SIFE.
No, I don't want an essay type answer. Everything is there on the slide. Okay, shall we give or not? No.
Magnetic cell separator.
Yes. Okay. Can go. Max. Yes, Max. So you got 20 points. So you want to take a gamble? You will get 40 points.
No, we don't want.
You don't want 40 points, yeah? So you can be leading. You don't want? Sure. Okay. Now let's go for the gambling question. So this is the interface fish. Okay. What does this interface fish on plasma cells show? Where green is 1p and red is 1q signals. So any of the teams want to answer, or from the audience, the complete answer?
1Q amplification? No.
What?
1Q amplification.
They're saying
You want the
1Q.
complete answer?
Amplification.
No. So there's a debate between amplification or gain. So what is amplification? What is gain? Yes, more than or equal to 4 copies is amplification. Only 3 copies, it is 1 gain. So what is the complete answer? Because you focus only on 1Q, 1p deletion and 1Q gain. Okay. So fine. So 1p deletion, 1Q gain. Right. Okay. Now audience question. So by the meantime, scorers can calculate. No team is getting any marks for this. So these 3 personalities discovered a chemical which is called kiss of death. What is that chemical for the audience? So on the answers? Cha.
Chemical is called kiss of death.
Right. For time saving, we'll work on this. This is ubiquitin. Right.
So
Fine.
that was some intense pace bowling by the quizmaster. Not many teams could score a lot. Team A continues to defend and hold their score at 30 points. Team B missed out a golden opportunity of scoring on a full toss, and they also stay at 70 points. We are going into a thriller here between potentially Team C and Team D right now. Team C managed to hit a boundary and have moved their score up to 90. Team D, after losing some wickets, they have sent Surya Kumar up the order and have smashed some runs and are leading with 120 points. And Team E holding fort at 60 points.
Right.
So give a big round of applause for all the teams as we now head to the slog overs of rapid fire.
Okay. To be clear, the team who is leading is team?
Team D with 120, followed by Team C with 90, followed by Team B with 70, followed by Team E with 60, and last Team A with 30.
Okay, fine. Now, very nice intense competition going on. Now let's go to round 5 with my Dr. Sumit. So it's a rapid fire round.
So the rules are simple. 1 minute per team. Please answer loudly and preferably only one person from a team. Now we'll start on the reverse order. Team E first and then to Team A. Each team gets 10 questions. No pass, no negative marking. If the primary team answers right, they get plus 10. If there is any other combination, wrong answer, no answer, or they want to pass, then 0. If you pass a question, you cannot come back to that same question even if you have some time left at the end of the 10th question. Is this clear? Team E? Timer is ready, scorer is ready. Now the time is 60 seconds. 1 minute. Rapid fire. We start with the first team, which is Team E. Starts now. Samples of plasma cell immunophenotyping by flow cytometry must not be refrigerated. Yes or no?
Yes.
Polyclonal kappa and lambda antibody fluorochrome conjugates are preferred for flow cytometric plasma cell evaluation. Yes or no?
Yes.
No. No.
One, yes or no?
Sorry?
Please answer one thing, yes or
No,
no?
no.
Okay. Myatal compared dash versus RD.
There are D.
DRD.
Okay. Dose of IV daratumab is
16 mg per kg.
most common cytogenetic abnormality in AL amyloidosis is Patisiran is a drug used in dash.
Elematosis.
Wrong. Hyperdiploid myeloma with trisomy 3 and 5 have the worst OS. True or false?
False.
Conventional dose of GCSF for stem cell mobilization is dash.
10 mcg,
Okay. Gene deletion 13q deletion myeloma is dash.
high risk.
Okay. So you will not be able to go to 10th question. Anyways, I'll give it. You can still answer this question. What is the machine in the blood bank?
Platelet agitator.
Excellent. But you could not reach there. Okay. If you don't know, then pass it. Otherwise, you'll miss the last question, which might be the easiest question. So samples for plasma cell immunofluorescence by flow cytometry must not be refrigerated. Yes or no? They answered yes, so that is correct. Polyclonal kappa lambda fluorochrome conjugates are preferred. Yes or no? They answered
no.
no. Incorrect. DRD was correct. 16 mg per kg was correct. 1114 wrong. Hereditary ATTR amyloid wrong. False. Correct. 10 correct. RB1 they could not answer, and platelet agitator was out of time. So how many did they answer correctly? 5. So they get plus 50. Next team. So rapid fire for next team. Here we start from team A. Okay. Scorer ready, timer ready. CD20 expression plasma cells common with IgG translocation.
Next.
Castor trial compared dash versus VD.
Carfilzomib.
Dose of denosumab for bone protection myeloma is
120 mg.
genetic partner of IgG in 414 is
Next.
the variable region of lambda 6 is the least associated amyloidosis. Yes or no?
Yes.
Mouse derived monoclonal antibody can interfere with IFE interpretation. Yes or no?
Yes.
Dose level toxicity to belantamab mafodotin is
Keratopathy.
risk of production of light chain MGUS2 myeloma is
1%.
dose of lenalidomide for both 5q deletion MDS and multiple myeloma is 25 mg per day. True or false?
True.
Identify this machine.
Apheresis machine.
Sorry?
Stem cell apheresis.
Apheresis machine. Excellent. So they are still in time.
Just about done.
Okay. So CD20 expression plasma cells is with translocation 1114. They did not answer. Castor trial compared DVD versus VD. They answered incorrectly. Denosumab was correct. 120 mg. IGH partner in 414 is FGFR3. They did not answer. Variable region lambda 6 is the least associated amyloidosis. Answer is no. What did they answer?
They answered yes.
Okay. Mouse derived MAP therapy can interfere with IFE interpretation. Answer is no. What did they answer?
They answered yes.
Okay. Belantamab was correct. 0.3% of light chain MGUS. They answered it incorrectly. Dose of len for both is 25. That is incorrect. For 5q deletion is typically 10 mg, and for myeloma it is 25. And AFRS machine they answered correctly.
So they get 3 right.
So plus 30. So next team, team B. You are ready? Scorer timer ready. Timer. Presence of more than dash percent plasma with deletion 17p as a short PFS.
5%.
Standard dose of melphalan for auto transplant myeloma is
200 milligram per kilogram.
approved dose of once weekly carfilzomib for as per Arrow study was
56 milligram per square meter.
mediated is acronym for
Pass.
most frequent cytogenic abnormality in non-secretory myeloma is
Pass.
Bellini trial compared dash versus placebo plus VD.
Pass.
Genetic pattern of IgG in 1416 is
MAF.
okay. Almost all patients with POEM syndrome have lambda-associated paraproteinemias. Yes or no?
True.
Malditov is less sensitive than SFLC in monitoring of light chain myeloma. Yes or no?
No.
Identify this machine or procedure. You might be doing it day in and day out.
Time up.
Okay. Anybody for the machine? Amongst irradiator. Excellent. So presence of more than 60% plasma cells with deletion 17p is bad. Melphalan they answered correctly, 200 per meter square. Sorry?
They actually mentioned 200 milligram per kg.
I'll give it to them. It came out in the husk. I will give it to them. I am a lenient quizmaster. Carpal tunnel, 70 per meter square, wrong. Meditate, acronym for, they did not answer. Non-secretory myeloma is 11-14. Venetoclax plus VD versus placebo plus VD. 14-16 is CMAF. I still gave it to them. Poem syndrome have lambda-restricted paraproteinemias. Yes, they were correct. Maldidov is less sensitive. Did they answer yes or no?
They answered no.
That was incorrect. This did not answer. So how many they could answer?
They got 3 right.
3.
Yeah, so they got 200 right?
Yes for the poems.
Yeah.
3 right.
3 right. Wrong, yeah.
They got it wrong, yes. So
three
plus
right.
30. Scorer ready, timer ready. We move on to team C. Syntecin 1 is commonly known as which CD molecule?
CD 138.
Myelomas with IgH MAF are more commonly associated with high free light chain levels and renal failure is a myeloma defining event. Yes or no?
Yes.
Dash is target type for 11-14 myeloma.
Venetoclax.
Endurance trial compared Dash versus Botoxin plus Dexa in NDMM patients without intention for transplant.
KRD.
Malditov can differentiate between immune reconstitution and reappearances of pathogenic paraprotein. Yes or no?
Yes.
Plerixafor inhibits interaction of CXCR4 and Dash.
CXCL12.
c-Myc translocation is primary static abnormality in myeloma. True or false?
True.
IMWG 2220 model is used for stratification of Dash.
Smoldering myeloma. High risk smoldering myeloma.
After mediated, most convertation in Waldenstrom macrolemia is...
CXCR4.
What is this procedure?
Centrifugation.
Day in and day out.
Separation.
What separation?
Component separation into like depends whether it's centrifuged or not. Plasma and RBC. So.
Leukodepletion. Syntecin 1 CD138, they got it correct. IgH MAF translocations with renal defining event, yes, they got it correct. Venetoclax, they got it correct. Endurance trial, they got it wrong. It was Carfil plus Dexa.
No, you said KRD, that's wrong.
Malditov, they said yes, so it was correct. Plerixafor, they told CXCL12, which is same as SDF1, so that is correct. c-Myc is not, so they answered incorrectly. Smoldering myeloma was correct. CXCR4 was correct, and last one they could not answer. So how many did they answer?
This is setting up interestingly going forward for the last team. They've got 7 correct.
Team C got 7 correct, plus 70. Give a big round of applause. So coming to team D, D for Delhi. Okay. Both Russell and Dusha are intracytoplasmic immunoglobulin inclusions. True or false?
False.
Determination trial used 1 year lane maintenance. True or false?
False.
Endometrial trial used Dash in combination with VCD.
Daratumab.
Dose of Plerixafor stem cell mobilization is
0.24 mg per kg.
genetic pattern of IgH in 1420 is
MAPC.
IgH translocated and trisomic myelomas are mutually exclusive. True or false?
False.
Name the bispecific which got FDA approval in October 22 for relapse refractory myeloma.
Teclistamab.
Dose of Ibrutin in Waldenstrom macrolemia is Dash mg OD.
420 mg OD.
Risk of progression of IgM MGUS to LPL is Dash percentage per year.
1%.
What is this procedure?
Cryopreservation. Thawing. Please.
I will not give it to you. I'm sorry. Because my co-quiz master will kill me. Okay. Russell and Dusher, they answered it correctly. It is false. Determination trial used 1 year lane maintenance. That is incorrect. So they answered it correctly. That is false. Endometrial trial used subcute daratumab. They told daratumab that is correct. Dose of Plerixafor, they answered 0.24.
Yeah, they answered
okay, correctly. IgH in 1420 was wrong.
They told MAF-C they said.
MAF-C bola.
MAF-C they were told.
Then it is incorrect because CMAF is 1416. IgH translocated and trisomic myelomas are mutually exclusive. They answered
said
it
false.
False, okay. Teclistamab, I gave it to them. Ibrutinib 420 was correct. IgM is 1.5, that was incorrect. And thawing was incorrect. So how many they could answer?
7.
7? Okay. Plus 70 to team D. So, final scores, please.
Do we announce now or do we announce Dr. Uday? Stay back for it. That's always the strategy. Yeah.
There is no tie?
There's absolutely no tie.
Excellent.
It's slender margins, but there is no tie, and we have clear top 3 winners.
Thank you very much. And over the dais to organizing team.
Thanks a lot to Dr. Sumit and Dr. Karthik. Special thanks to Dr. Nitin for conducting the prelims round and the final round in such a smooth way. And it was really, the questions were really mind-boggling, good, and were real time. So thank you. Now I request Ms. Pankti to take over for the next session. We require 2 minutes to just load the next session, please.
A very good morning to all. We are thrilled to have you join us as we begin day 2 of the 5th annual meeting of the Indian Myeloma Group. We begin with our CME talks for the day. Our chairpersons are Dr. Govind Babu and Dr. Neelam Verma. Dr. K. Govind Babu is consultant in the Department of Medical Oncology, HCG Cancer Center, Bengaluru, and Dr. Neelam Verma is ex-professor and head in the Department of Hematology, PGI Chandigarh. We graciously invite them to the dais to introduce the speakers.
Good morning. So we start the first session of the conference proper now. We have the stars of Indian Myeloma Mafia with us for our Myeloma Congress, and I'll borrow the comment made yesterday that if you don't know them, did you get my earlier comment or no? Yeah. So if you don't know the stars of Indian Myeloma Mafia, then you don't belong in this hall. But anyway, for the sake of completion, I'll invite the first speaker. He needs no introduction, but yeah, so over to Dr. Vincent Rajkumar. He's a professor of medicine at Mayo Clinic. Over to you, Dr. Rajkumar.
Hi everyone, really great to be here. I haven't visited St. John's before, and it was really nice to, Hari gave me a walk around the campus. It was really nice. Thanks for having me. And I was sitting at the back and listening to the quiz. I'm kind of feeling intimidated because you guys know the type of details that I just simply cannot remember this kind of stuff. But look forward to having a good discussion, and today we'll talk about strategies. That's the topic given to me, strategies to optimize treatment outcomes in patients with transplant-eligible, newly diagnosed multiple myeloma. So I think in a nutshell, there are probably 5 ideas that that come to mind on how to improve outcomes for this group of patients. You must know the real world data right now from both Canada and Emory suggests that patients with transplant eligible newly diagnosed myeloma have a median survival of 13 years, which is quite good. And even high risk patients have a median survival of about 8 years or so. So how do you improve on that? And even those results probably underestimate what can be achieved because they don't take into account the benefits of immunotherapy. Clearly, we've been thinking of myeloma as one disease, and one way to improve outcomes would be to start thinking of it as multiple diseases, because we may have to adjust our treatment based on how much risk the patient has. We are doing that to some extent with the risk stratification, with high-risk myeloma patients getting more intense induction, more intense consolidation and maintenance. But we may have to look even more deeper into what we can do for patients who have more than one high-risk abnormality, so-called double-hit myeloma, or patients who have multiple high-risk abnormalities like triple-hit myeloma. And also maybe individualized treatment for certain types of cytogenetic abnormalities, as you heard with venetoclax for 11-14 translocation. So the field needs to evolve where we start looking at myeloma as multiple diseases, and we in the next several years improve outcomes by treating certain categories of patients in the more appropriate way in which you can overcome their problems. The second approach, of course, is what we are all currently dealing with the most, which is how to improve induction therapy, or what is the best induction we can give. And the goal here is to see if we can get the disease to as good of a response status as possible, to reduce the tumor burden as much as possible. And so clearly many regimens are used. A lot of the randomized trials, though, which establish the two regimens we use commonly, VRD or DARA-RD, are really started off in the non-transplant clinical trials. This one is the SWOG clinical trial, which really didn't have transplant as built into the part of it, but that's what we use to say VRD would be a good induction regimen. There hasn't been a good VRD versus RD, for example, a transplant induction trial. It's harder to show an improvement because you're only giving 4 cycles of induction. So no matter what you do after all is said and done, the transplant and maintenance equalizes it. But clearly, VRD alone as an induction regimen is a great regimen because it's been studied in multiple phase 3 trials. The SWOG trial, then the determination trial, the IFM trial, all of them use VRD as frontline therapy. We have a lot of experience using it. And we know that even without transplant, patients can get a progression-free survival of 4 years. It's certainly better